liaise with him?
Yeah.
Oh, Teresina maybe.
No,
She's
we
away.
don't go to CIS as far as I'm aware.
Okay, let me just check.
Yeah.
So I don't know why he has sent me this, because we are Westminster.
Well, potentially his colleagues are either having discussions with Rehab or Home First.
It seems like.
And they're declining referrals.
Yeah.
For what?
We should all be able to watch it. And if there's more need, I can do another round next week. Again, as I said earlier on, questions, if you have any, type them into the chat function. You can find it in the bottom where it says chat, and you open it up and type your questions in. Michelle is here to support, and she'll also be hopefully in real time be doing the questions. And then of course we have the thumbs up and the clap functions. So if you wanted to show those, they should be on the bottom right corner for you to use also. Let's do a very quick round of introductions, everyone. Thank you very much for showing the thumbs up function and the clap function. Very quick round of introductions. Michelle, do you want to start?
Hi, I'm Michelle Gardner. I'm a nurse by background, those of you who don't know me, and I'm the borough lead in Kensington and Chelsea, CIS, helping Karin today, just answering your questions. Pop them in the chat and I'll do my very best. If I don't know the answer, Karin, I'll come back to you with something after.
Next on the chat, I've got Fiona Buckeridge. Do you want to introduce yourself quickly?
Hi, I'm Fiona Buckeridge. I'm the interim rehab lead in Westminster. Hi.
Welcome. Thank you for joining. I've got Bhavna on.
Yes, hello. I'm Bhavna, I'm one of the physios, Band 7 physios in KNC Rehab team, currently helping out Home First team. Thank you.
Thank you. I've got Anita Phillips.
Hi, I'm Anita, physio in Westminster, Band 7, also helping out with Home First at the moment.
Welcome. Fowler, I've got you on here as well. Will I mute you? You need to mute yourself. Ah, here we go.
Okay, hi, it's Fall. I'm one of the nurses at Hammersmith and Fulham. Good morning.
Good morning, welcome. Great, I've got Catherine there as well.
Hi, I'm Kate. I'm one of the community physios in Westminster, working in CIS but helping out Home First now.
Welcome, thank you for joining. I have Blago Ned. We can't hear you. You have unmuted yourself, but you sometimes also need to switch up your audio on your computer. Still can't hear you. I'll let you deal with that and move on for the time being. We'll come back. Welcome back. Good. I've got Rebecca Gow. Unmute.
Hello, good morning. I'm Rebecca. I'm the rehab pathway leading KNC. Good morning.
Thank you, Rebecca, for joining. Good morning. I've got Bex walking around here.
Oh, hi, I'm Bex. I'm a care coordinator and admin team lead at Kensington CIS.
Welcome back. Thank you for joining. Next is Alex Konopka.
Hi, I'm Alex. I'm Home First team lead in Hammersmith and Fulham.
Welcome, Alex. Thanks for joining. Gwen Hopkins.
Hi, I'm the pharmacist for Rapid Response in H&F and supporting the Home First and reablement teams as well in rehab.
Thank you, Gwen. Welcome. Winnie Roberts. Hello, good morning.
Hi. Hello.
Quickly introduce yourself.
Hello. I'm Winnie Roberts. I'm one of the case managers with Hammersmith and Fulham.
Welcome.
Hi.
Thank you for joining. Sabi?
Hi everyone, I'm Pathway Lead for Rapid Response in Hammersmith and Fulham.
Welcome, thank you for joining. T_Sampson H. How are you in there?
Hi there, I'm an OT at the Hammersmith and Fulham Memory Clinic, but I've been redeployed to Home First, Hammersmith and Fulham.
Welcome, welcome.
Hi, thanks.
Costas Nunes.
Hi, good morning. I'm a nurse, rapid response nurse in Hammersmith and Fulham.
Welcome, thank you for joining. Saima Chaudhry. Need to unmute yourself. No? Who are you with, Jess? Who are you
I'm
with?
just looking at it from here, otherwise I'll get feedback.
Okay, fine. Yeah, can't hear Saima, but maybe she's on mute. I've got Edmund Turner.
Good morning, I'm a physio in Westminster.
Welcome, thank you very much for joining, Edmund. And then Hanan Said.
Hi, I'm a care coordinator at Hammersmith and Fulham. Hanan.
Hello, good morning. Thanks for joining. Shall we try again? Blago Enet? Last one? Not working? Okay, welcome anyway. Good morning. Okay, thanks everyone. I think I have everyone here. In the room with me, I have Jess, physio in Westminster, Rapid Response. And I've got Brian, physio in Home First now. And we know that our Westminster Rapid Response Pathway Lead is going to join us shortly. She's probably popped out at the moment. So she's going to be in the room here also. Okay, let's get started. Again, we're going to talk about the respiratory management of patients during COVID-19 today. And that's a big, following that presentation is following on the recent updated NHSE guidance that came out. And the link to this guidance, if you want to read the full document, is here in yellow. This guidance keeps on changing, probably on a weekly basis at the moment, as with a lot of NHSE, NHSI documents that just keep on adding things to it, which is useful, but again, then also makes the document longer and longer. So I think the baseline is covered, but again, I think it's probably worth revisiting this document on a more or less regular basis to see what else has been added. The key messages of the presentation today is really, unless everyone is being tested in the community, the message from NHSE is every patient we see should be assumed to be COVID-19 positive. And I think we have been doing this anyway in regards to using PPE with all the patients who we see at home. Again, social distancing, reduce unnecessary exposure to potential sources of COVID-19. I think that has been all over the media, risk to patients as well, risk to staff. Triage and assessments of patients by default doing it remotely. So the first step to make contact with the patient is not to visit them, but to remotely triage them via telephone or preferred video consultation. But most of the time that's already being done for us by the referrer, who is either the GP, LAS, 111, the acute hospital, but again, nothing stopping us from making another phone call to this patient and see if we can get a bit more information prior to visiting. I'll come to that in a little bit. NHSE also says that face-to-face assessments of patients should only be undertaken when it's absolutely necessary. So when we really have to do a physical assessment of the patient, where the benefits of doing so outweigh the risk. I think that's probably actually most of the patients we see, because the patients who are referred to us probably do need an assessment face-to-face because they're high-risk patients with comorbidities and high risk of being admitted or readmitted to hospital. But I'll go through this in a little bit later around what we can do. So the first part of what I'm going to be talking about is the remote assessment / telephone triage of the patient or the patient's carer and what NHSE recommends. So of course, the first step should be to screen the patient for symptoms of COVID-19. And I hope you all know the screening questions, which is a fever above 37.8 or a new continuous cough that's different to the usual one. NHSE says if they don't have a thermometer and they can't check the temperature, we should also ask if they feel shivery, achy, or if they're hot to touch. That's standard COVID-19 screening, and we should be doing this with every single patient we see. So we know the potential COVID-19 status or suspected COVID-19 status. The next step, after we've assessed any the patient for any COVID-19 symptoms, should be a screening for the severity of the illness. So there's quite a few questions we can ask the patients. I'm not going to read them all out for you now. You can read them yourself. You can ask them over the phone or via video how they are and how their breathing is, how unwell they may be, and how short of breath they may be. So that's suggested questions by NHS England, and I think they're quite sensible questions. Of course, there's also at the end a question around red flags such as collapse, chest pain, signs of sepsis, or confusion. So those questions can be asked over the phone and screened remotely. Further points NHSE is making, as I said before, in the first instance, the patient should have a consultation via phone or video. Well, often that's already done by whoever refers the patient to us, but nothing is stopping us to pick up the phone or the video again. When we decide to visit the patients, we should minimize the time of exposure to the patient. That's good for us and that's good for the patient as well, I suppose. NHSE recommends that in an ideal situation, we'd want to take the history remotely, as well as discuss the planning of next steps remotely. So what we could do is we could pick up the phone to the patient, get the history remotely, then go and assess the patient clinically, which we need to do when we need to examine them, then leave the house with the expectation that we're going to call the patient again later on today to discuss the management plan and next steps with them. This way, we reduce the time that the patient is exposed to us, and of course, reduce the time we are exposed to our patients, in a sense, despite the use of PPE. Again, examination should be done face-to-face. It's probably nothing we can get around it. If an ambulance is required and we need to call 999, it should be good practice to also hand over the COVID-19 status of the patient. So they have put some really nice flow charts into this presentation, which is looks quite confusing in the first instance when you first look at them, but actually they are, when you look at it a bit in more detail, they are not too bad. So the first flowchart I have here is the COVID-19 symptoms in the community. Patient is at home and presents with a new continuous cough and or a temperature of or above 37.8. Today specifically, I just wanted to focus on the right side of the presentation, which is the category 1 patients with severe symptoms and the category 2A and 2B patients with moderate symptoms. Category 1 breaks it down into quite severe presentations, quite unwell presentations of patients, with the outcome either being a 999 hospital admission or a consultation or discussion with the patient around advanced care planning or palliation. And probably most of these patients who we see probably do need a face-to-face assessment We may decide on triage that they need to go to hospital. We may decide that they need to go to hospital after we've seen them. We may decide that we can keep them at home. We may decide that on discussion with the patient's GP, they need an end-of-life care plan and a DNR if they haven't had it yet. Going on to cut the moderate symptom category, category 2A and 2B, I'd say it's probably the majority of the patients who we see in rapid response and home first. These are patients who are neither have mild symptoms, who can stay at home safely, or nor have really severe symptoms. So they are sort of right in between in the gray area and potentially on the border of deterioration. And NHSE has very kindly given us a second flow chart for that. Michelle, are you still on the line with us?
Yeah.
Here?
Yeah.
Could you?
The second flow chart hasn't come up.
No, the flow chart comes after the case example 1 and 2. Yeah. Would you mind running us through the case examples?
Of course.
Keep an eye on the chat in the meantime. It just helps me a bit with talking.
Yep. So the case example that we're looking at is an elderly man, 89, who's been referred in by our GP. You putting the boxes up, Karen?
No, I'm putting it down again, sorry.
Underlying COPD, lots of mucus and a fever for the last 2 days. Past history of ex-smoker, CKD, diabetes, ischemic heart disease, and has falls. The holistic assessment is that they live alone, they have a key safe. There's no advanced care or DNAR. We would be planning to assess for a chest infection, do an overall phone call, short of breath, at rest, unable to speak in full sentences, which are all the questions that Karin just mentioned, and they're coughing. But they don't want to go to hospital at any cost. We've seen this quite a lot recently, more so than in the past. People just don't want to leave their homes. So what would we be thinking and what would be the next things we do? I've preempted the boxes, Karin.
Thank you. Feel free to speak up.
Any ideas, anyone? What would you do next? When you were there doing the assessment, you've gone out for a face-to-face.
Obviously have the PPE ready, offer the mask, and just start off with that and then introduce yourself, and as the patient's coughing, hear out for the rattling sound that you can understand whether they are currently, I mean, you've already told us, haven't you, the green sputum. So, and then begin your physical assessment. So auscultation, palpation, percussion, and strength of cough, just a bit of a assessment, how much strength have they got, and then accessory muscle use, and how are they able to clear, and again vital stats, so BP, blood pressure, temperature, pulse oximeter, saturation testing, and yeah, so just carrying on from there.
Great, thank you. Anyone else?
You might want to do the News 2 score, so you could communicate that to the other professionals.
Yeah, important to do a News 2 on this man. What would you specifically want to look at in the News 2? Which parameters with this man?
Respiratory rate.
And SATs as well.
Yeah, yeah, great. Any other plans for this man? Sorry, I'm sort of looking in the room. You don't have to say anything. There's other people on the call who can talk. Anyone else? What are we going to do with him after we've done our assessment and calculated our news 2 and done the full examination? What's the next step?
Are they on any antibiotics if they've got chest infection?
Not yet.
To contact the GP.
Yep.
End of life discussion.
Say it again.
I said end of life discussions.
Yes, because the GP may want to consider that, isn't it? If the patient is very unwell and definitely doesn't want to go to hospital at all cost. Of course, it could be that he deteriorates at home and potentially passes away. So, yes, that's probably a good one.
Why doesn't he want to go into hospital?
Don't know. We ask him.
Maybe explore that.
Yeah. So potentially he doesn't want to get COVID-19 and die in hospital. So he says if he wants to die, if he dies, he wants to die at home. If he doesn't survive this episode. So
you would also consider capacity at that point when you're having those discussions as well. Just make sure that the right decisions are being made with regards to the not wanting to go to hospital at that point.
Question, is this patient a potential COVID-19 positive patient?
Potentially.
He has a key safe, so you might have carers coming in.
Yeah. Would we say this patient has an exacerbation of COPD, or would we say this patient potentially has COVID-19? What does he have?
Well, unless testing is done, we don't know for certain, but you would assume.
It's COVID.
Yeah.
Yeah.
It's got a temperature.
Absolutely. Yeah. So I think this is a typical patient who we could see in the community. Of course, he almost certainly has an exacerbation of COPD, given his underlying condition, fever, green sputum, coughing, shortness of breath. But in the current situation, we would very much treat this person as a potential COVID-19 positive patient, even if we do not have community testing, because of the symptoms he displays. So I think that's important to note. Good. I'm going to move on to the next example. Michelle, will you help me?
Yep. Elderly lady, 92 years old, and LAS is referring us into the service. The crew are at the scene. No respiratory history for 3 days, but 3 days of fever and coughing. Past history of osteoporosis, partially cited, HTN. Lives alone and has a care package. Again, no advanced care plan or DNAR. Speaks in a full sentence, saturation's 94, respiratory rate 20, BP 140 on 95, heart rate 98, and regular, temperature's 37.8. What are our next steps?
What are we going to do with this patient? Are we going to accept this patient, go and see this patient? Are we going to decline this patient? Is this patient too sick to stay at home? What are we going to do first with this when we get that phone call from LAS?
What is the referral for? What do the LAS want us to do?
They want us to monitor the patient at home because the patient doesn't want to go to hospital. Monitor / treat the patient at home. What's the News 2 score? Let's start with that. Able to speak in full sentences, SATs 94%, respiratory rate 20, blood pressure 140 over 95, heart rate 98 regular, and temperature is 37.8.
And make it about 1, but I might be wrong. Not high one, not a high news score.
True, that's correct. Yes, yes, I think it's 1 or 2. It is a low news 2 score. So does that tell us the patient is actually really well and it's okay to stay at home?
No, not necessarily.
Yeah. What about the COVID-19 status? Is this a patient who has COVID-19 or not? Are we suspecting COVID-19 here?
I think so, because of her symptoms.
Yeah.
She has a new onset of fever and cough, and the temperature is 37.8. If we look at the SATs, they're 94%. So, question mark, is it a normal? She doesn't have any COPD or respiratory history. So, again, that would be quite a typical presentation of COVID-19. She doesn't want to go to hospital. She wants to stay at home. So what would be our next steps? Gonna go and see this patient? Would we go and see them? Yeah. PPE? Yeah. PPE, see the patient, assess them?
As long as the patient knows that she's likely to die at home.
Yeah. Yeah. So I think again it's a capacity assessment once again. Is the patient aware that she may deteriorate and even potentially die at home, which we do see quite a bit at the moment. If she doesn't want to go to hospital at all, understands what her potential symptoms are and what we can do for them in the community, and potentially if she lives alone and she only has carers PD, does she need an increase in her care package? And I guess how do we treat her on basis of the examination, feedback to the GP, what do we do with her? And then of course, is there a need for an advanced care plan and a DNAR, given that she's 92 and is presenting with symptoms of COVID-19? So certainly something to suggest, I would suggest to the GP. Okay, so these are probably typical patients who we see at the moment. That's the second part of the flow chart now. So, and this is again, focusing on the previous flow chart, the medium risk patients, category 2A and 2B. They're broken down a little bit more into different categories. And specifically, I wanted to draw your attention on NHSE guidelines suggesting that patients could potentially take their own temperature or potentially their blood pressure and some of the OPS measurements themselves at home if they know how to do that. That's a suggestion from NHSE. And then, of course, the 2 scenarios we just went through is on the right-hand side, the suspected COVID-19 cases with respiratory complications. And very helpfully, they are being broken down further into a patient group that are either high risk, medium risk, or low risk. I forgot that thing around it, for deterioration and how we should monitor them and how we should manage them. It gives us a good indication of what the SAT should be, what the heart rate should be, what the respiratory rate should be, and again, around deteriorating patients. So I think that's quite a good flow chart. I will share the presentation. You can look through that, but I think that's probably the most important part out of this flow chart. Moving on, they give us specific recommendations of number 1, patients who have a history of asthma, and number 2, patients who have a history of COPD, which is in the next slide of that one. They suggest that, of course, asthma is not part of the rapid response referral criteria. Nevertheless, we still will see patients who have underlying asthma and may not present with asthma. So if the 2 key messages from this slide is that if we are thinking about, does this patient have asthma, an exacerbation of asthma, or may they have COVID-19, the suggestion here is that if they have a high temperature as well as a change in taste or smell with the exacerbation of asthma, we are probably suspicious that there's a COVID-19 infection as well. And the recommendation is that whatever we do with these patients, when they have underlying asthma and they're taking steroid inhalers, we shouldn't be stopping the steroid inhalers at all. There's been recent discussions around whether steroids could cause a deterioration in patients with COVID-19. Certainly, the recommendation is not for asthmatics to stop their steroid inhalers, to all to continue with that. However, the recommendation is slightly different in patients with COPD who don't have underlying asthma or are very responsive to steroids. There should be a careful assessment whether we should give patients with COPD steroids, most likely oral prednisolone, if we treat the exacerbation. There is also a nice algorithm here which differentiates mild deterioration, moderate deterioration, and severe deterioration of COPD patients based on their pulse oximetry, so their baseline SATs, and how much they've deteriorated off the baseline. It's important that we find out the baseline. We should either have this in the notes or the GP should know what the baseline SATs are. If they have respiratory team input, we should definitely check with our respiratory team as well and see if they could take over the care of the patient, the co-manage the patient with us, and see what the severity of the deterioration is. There's another sentence here around patients who are on long-term oxygen therapy at home. They should consider to be admitted if the SATs drop below 88 on the standard dose of long-term oxygen. So for example, let's say if they're on 2 liters standard dose via nasal cannula regularly, despite the oxygen, on the oxygen, if the SATs is below 88, that we should consider admission. Again, if they are on long-term oxygen, they should also be under a respiratory team. So it's important that we pick up the phone and talk to our respiratory team about those patients, potentially prior admitting them, to see how they want to manage them. So I think the key messages is, in asthmatics, do not stop the steroid inhalers, continue with the steroids they're taking regularly. In patients with COPD, I would probably discuss with the GP if they have a rescue pack at home, whether they should take the prednisolone or just take the antibiotics. Given the recent evidence, these guidelines may change. So we'll watch the space. Treatments to be considered at home. There's a clear recommendation of which antibiotics people should have, either doxycycline or amoxicillin. Again, if someone has asthma and an exacerbation of asthma, prednisolone should be given, but ideally we need to just think about it twice whether patients with COPD should have it. Again, the high-dose bronchodilator, salbutamol at home, that's not changing if they need it. Nebulizers, the advice on home nebulizers stays the same. People should not be encouraged to buy or loan nebulizers unless our respiratory team tells them to do so. So that shouldn't be encouraged. And really important to note that there's currently no home oxygen pathways for patients with COVID-19. Again, we need to see in the next 2 weeks whether this is going to change or not. So watch this guideline. At the moment, there's no recommendation for home oxygen for patients who are managed at home with COVID-19, who are either short of breath or who desaturate. This is just a slide around managing breathlessness at home for the patients. That's in the appendix of the guidelines that can be printed out and given to the patient. If they understand it, they can read it. There's some breathing exercises and how to keep them comfortable. The second part of the presentation, I'm aware that we are sort of a bit short of time, but there's a short as well, is around if we go into the patient's home and actually do a face-to-face contact with patients who are suspected COVID-19 positive. And again, I'm not going to elaborate on PPE in this presentation. That's a whole different topic, and Michelle is very kindly covering that in a lot of her presentations. But NHSE says adhere to the current recommendations. Again, the patient can be asked to wear a mask themselves, and they can be passed a letter box before entering, if it doesn't bother the patient too much. If we are not examining the patient and we're just talking to them or taking a history, which ideally should be via phone or remotely, we should be keeping our 2-meter distance. So once you've finished your examination, step backwards and keep a distance from the patient and the relatives if possible. It's recommended to not perform chest physio, not perform spirometry, not perform peak flow, or any other aerosol generating procedures in the patient's home. This includes an induction of sputum, which is different to coughing. So sputum samples, the need for sputum samples should be discussed with either the respiratory team or the GP in the first instance. If it's absolutely needed, my recommendation would be to either leave a sputum sample pot with the patient, to bring it up in their own time, collect it the next day, or to step outside whilst the patient is doing that, so we're not exposed to an induction of sputum. Monitor the patient's observations and use 2 score. Very strong emphasis on advanced care planning and the use of coordinate my care. And again, quite clear around calling and escalating to 999 or advanced care planning, and making a clear plan, which I think all of us are doing anyway, when we're going to make contact with the patient again, and dispose of the PP after the visit. Again, I'm not going to go into that today. So there is just one last part of the presentation, which is called business as usual for non-COVID-19 respiratory patients or smokers. So again, there is a few links on there, which is reinforcing government guidance on social shielding for 12 weeks. There's a link from the British Lung Foundation for us to look up, or the patients to look up, that explains what social shielding is. And there's a link from asthma.org.uk about triggers and about the treatment and control of coronavirus in asthmatics. And just right underneath, I have also put the link onto here, which is the government's extremely vulnerable list of patients, where patients can either register themselves on for additional government support, or relatives, carers, or even healthcare professionals ourselves can do so for them on their behalf. So you can look at that in your own time. Clearly make sure the patient has sufficient medication at home. Clearly check what the sort of, with COPD patient, what rescue packs they have. And once again, re-emphasize the use of prednisolone and the discussion with the GP prior to starting that. Patients should be having a home thermometer, at least at home, to check the temperature, plus minus a pulse oximeter. That can be bought on Amazon if they wanted to. This is just a repeat of what I said earlier on around the use of steroids in asthma and COPD, as well as advice on pulmonary rehab. Most pulmonary rehab services are suspended at the moment, but they are often supporting people remotely at home. There's again a link from the British Lung Foundation on there, which you can look up. My last slide is around cardiopulmonary resuscitation. As you're all aware, the guidelines with COVID-19 have changed, and they do emphasize that we must not use mouth-to-mouth ventilation if a patient needs CPR. The Resus Council says that performing chest compressions and defibrillation of the patient is not considered an aerosol generating procedure, and therefore can be commenced whilst we are waiting the arrival of an ambulance to undertake airway maneuvers of the patient. And I think important for us is the last sentence here, that on arrival of the ambulance, the first responders who have performed the chest compressions and the defibrillation should leave the scene before any airway procedures are carried out, because of the potential risk of aerosol generating procedures in this case. I can see there's quite a lot of comments or questions in the chat here. I am finished with my presentation, but I can see a lot of the comments are from Michelle.
Yeah, it's primarily just comments with regards to some of the questions that we had yesterday, just keeping people getting the same message, and just reiterating some of the points that you've made, Karen, so that people could read back, just sort of covering out some of that. And one of the questions that came up yesterday, just I think you answered it in the last page there. If you can just go back before the cardiopulmonary resuscitation to the last page, this one. So the concern around the use of inhaled corticosteroids for asthma, patients have started to use their preventatives much more thoroughly. And the question yesterday was, if someone has been non-compliant or not using them, should we advise to take them? There's nothing saying that we shouldn't, but if they haven't been using them, you probably should go back to the GP and just check that they want us to add that in. People probably will have started taking them, but there's a little bit of a grey area, because we have lots of people who don't always take their brown or their corticosteroid, but they will take their blue inhaler or salbutamol very regularly.
That's specifically for asthmatics?
Specifically for asthmatics, yes. I tried to get a definitive answer a little bit more yesterday by reading up things, but it isn't real clear about that one if people haven't been taking it regularly.
No, there isn't. I think asthmatics on a standard inhaled steroid dose should definitely be taking it, as steroids in asthmatics are probably necessary to reduce an airway inflammation or an exacerbation of asthma. But again, and again in the sentence here it says steroids are not thought to increase the risk of COVID-19 infection. However, I think the reason why it's not recommended so much in COPD opposite to asthma is because steroids do seem to increase the risk of secondary pneumonia, which is obviously then more likely to happen in COPD patients. And I think there's still probably, I'm assuming, watch this space, there's probably more details to come.
Yeah, I think it was a concern around, if someone hasn't taken it for a long time and they've found one in their drawer at home, what do we do with that? And that's why that sentence is quite important. It's not thought to increase, and just as we remember that when we're having those discussions with an asthmatic.
Oh yeah, so I just wanted to say one more thing to that. A lot of asthmatics, it might be worth then also, if they find a steroid inhaler in the drawer, it might be worth checking with their GP, because they may know the history and the history of exacerbations, hospital admissions, and the risk of it, and how they've been managing the asthma in the past. So it may be an individualized decision by the GP with the patient how or if they should start the steroid inhaler. So they will often be knowing more about the patient's background and how well or not well the asthma had been managed in the past. So I guess there's always the case of being able to feed back to the GP. One more question here. In case of a patient with no COPD background, now coughing up, do we give breathing advice through leaflets only? We aren't doing chest physio. Yes, is the answer, I think. The short answer to this question. We are not doing chest physio face-to-face with the patient at the moment, because of the risk of an aerosol generating procedure here. But again, They can be advised remotely, either via leaflets or phone or video consultation on how to do it, and guided through them, and then do it when they're by themselves and not.
They can be put on the list to be seen after the COVID episodes.
Yes,
We
yes.
can get back to them for that routine work later.
For the routine work, yes, absolutely.
Okay.
So Brian just said in the room here that we can get back to patients after the COVID-19 outbreak, whenever there is an after. Not going to be negative here.
With COPD patients, they already have the techniques of breathing.
Most of them should do, yes. But again, there is good leave. Yeah, again, depending on, again, it's an individual assessment, isn't it, of the patient, whether we should give them leaflets and guidance now. Again, pulmonary rehab does remote assessments, and the respiratory team is there for advice also, and they can help us guide through that. Are there any more questions to all of that? I know it's been quite as usual with my presentations, quite a condensed presentation with lots and lots of info, and squished into 1 hour or a bit less than an hour. I am recording this presentation. It went a bit better than yesterday, I'm pleased to say, because I didn't lose power right the way through. So yes, thanks Michelle for clapping. So I'm going to be uploading the recording onto Slack. So whoever wants to be added to a Slack channel, which I own, and look through some presentations about news 2 or this one now, please send me your email. I can add you. Otherwise, I will send the presentation around, the slides around, if you haven't had them already, so you can read them in your own time. That guideline, the link to the guideline on page 2 or 3 of the presentation is likely to continuously be updated on a weekly or bi-monthly basis. So please watch that space. Is there a comment or one more question? Just circulate this last station. Thank you very much, Sabi. Thank you very much, Michelle, and everyone else for dialing in. That's my last slide here. I hope everyone knows what it is and where it is. Wembley Stadium. Thank you, NHS. Thank you, everyone, for all your work and for listening today.
Thank you. It's very good. Could you add me to Slack as well? Could you add me to Slack?
I will do, yeah.
Yes, please. Thank you. It's a valuable presentation, especially with them on a daily basis. So there's quite a lot of anxiety going on.
Karen, if you need anything, email me. I'm back on Sunday. I'm having tomorrow off.
Thank you very much, everyone. Have a good day off. Hopefully, if you're not working for the weekend, then enjoy. Take some time off.
I'm working Sunday. So
take some time off. Take care. Don't work today. Thank you. Bye-bye. Bye-bye.